But yeah, so I am the clinical director for the Bing Center for Waldenstrom's Macroglobulinemia, the Dana-Farber Cancer Institute. The Bing Center has become a big production now. I mean, we have a big laboratory. The clinic, we have about 6 people in the clinic now. We have a number of clinical research coordinators, nurse practitioners helping us to see the patients. And we are trying to make sure that the patients are important part of the decision making. And for that, we need to have patients who are informed, patients who are educated, patients who will be their best advocates, their own best advocates to take care of themselves. Not only Waldenstrom's is a rare disease, as you will see, but it presents in very quirky ways. And you as Waldenstrom patients don't know that better than anybody else around you. It's a quirky disease, you know, so nobody in this world can tell you they know everything about this disease. I personally do not know everything about this disease. But as much as we are trying to advance the science, we're trying to learn more every day. And that's exactly what we're doing in the clinic. So today, we're going to be talking about treatment options. I was supposed to be speaking tomorrow, but Dr. Leah Palomba had some other things to, attend, and then I will switch to Saturday. So she will be talking about, clinical trials and future treatments for Waldenstrom's. Today, we're going to talk about what is considered standard. And I didn't make a very long presentation, so it's going to be a kind of a short presentation, maybe 30, 40 minutes, so we can actually go to the questions, which is, I think, is the most important part. Now, for the questions part, I'm happy to answer the questions. Let's make sure that those questions are not specific to you, because otherwise it's going to be a liability to me. Since you are not my patient, I want to give you specific recommendations. That's not something I will do. But I can give you definitely some generalities and, go back to your doctor. And my email address is there. Please provide this email address to your doctors. And if they want to communicate with me directly in a doctor-to-doctor communication, which is the right way to do things, then I'd be happy to help in any way possible. So that's that. All right, so this is the man. This is Dr. Jan Waldenstrom. He since has passed, but he described this disease in 1944. Now, Dr. Waldenstrom not only described Waldenstrom's macroglobulinemia, he described a number of diseases, autoimmune diseases, specifically autoimmune hepatitis. I don't know why this is moving on its own, but he described autoimmune hepatitis. He described a series of immunodeficiencies. He was a very prolific clinician in the 1940s. And one day he was being praised of, how many things he did for medicine. And he essentially said, well, I'm just a clinician. And this keeps moving. I'm just a clinician, and I just report what I see. I describe what I see, And in that specific regard, yes.
Keep going.
Okay. In that specific regard, he was very humble, But that's exactly what we do in the clinic. We need to be, up to date with whatever comes out from the laboratory. We need to make sure that we understand the biology of the disease. We need to make sure that we understand how these medications work, but from the biological perspective. But how the biological perspective will transfer or transform into what we call the clinical care, that's a different story, because we can do many different things in the tube. We can do many different things in rats. We can do many different things in animal models. But what actually happens in the patients, that cannot be predicted by any type of study or laboratory study of any nature. So for that specific reason, it's very important to see the patients and to gather the expertise so we can, be clinicians and take care of patients. So Lou mentioned that Dr. Trion hired me about 4 years ago when the MYD88 mutation discovery came out. And I think he did that specifically because of that, because he realized that after that discovery, he was not going to be able to do everything anymore. It was and so he needed somebody who will see patients, who will have that clinical acumen, who will care about the patients, who will run the clinical trials. And that's exactly what I've been doing for the last 4 years, and I couldn't be happier. So let's, since this laptop seems to be pushing me forward, so let's try to do it at the laptop's, rate and pace. So first of all, that's way too fast. All right, so first of all, the diagnostic criteria for Waldenstrom, this is an important point, because many patients that come to see me are still confused. Even some doctors that I talk to, they're still confused. In the sense of, is this a lymphoma? Is this a myeloma? Exactly what type of disease this is. So based on the diagnostic criteria that we have, the most recent WHO criteria, it is a lymphoma. It is actually a type of lymphoma called lymphoplasmacytic lymphoma. And the interesting part of that is that most lymphomas have one clonal cell, lymphocytes. For lymphoplasmacytic lymphoma, we have 3 different families of clones. We have the lymphocytes, we have the plasma cells, which are the ones that are clonal in myeloma, and then we have some intermediate form between a lymphocyte and a plasma cell called lymphoplasmacytic cell. And the small ones are the lymphocytes, the large ones are the plasma cells, but we do have some intermediate forms that are not too small, not too big, so they are exactly between a lymphocyte and a plasma cell. So they used to be called plymphs. I don't like that name. So lymphoplasmacytic cells makes a lot of sense. So in 99% of patients with lymphoplasmacytic lymphoma, we will have this finding in the bone marrow. And that's why we have to do bone marrow biopsies on these patients. And pay attention that I said 99%. Right? That means there is a 1% of patients with Waldenstrom's who will not have bone marrow disease. They will have lymph nodes, they will have liver or spleen enlargement, they will have other potential areas where the disease is nesting, but the bone marrow will not be one of those. So we sometimes can, talking about a ball coming from left field, right? That's exactly what it is. So the interesting part about this disease is that these cells produce an antibody called IgM. And we all have IgM. The individuals without Waldenstrom's have IgM. But we have a defined amount of IgM circulating in our bloodstream. But in patients who have this excess of cells that produce IgM, then it's not unusual to see the IgM creeping up, right? But we need to be very careful too, because one would tend to assume that there's a relation between the amount of marrow disease that you have and the amount of IgM that is circulating in your body. That might not be completely true. But for purposes of the diagnostic criteria, if we have a picture like this in the marrow and an elevation in the IgM, and this IgM is monoclonal, we add a third aspect which just came out last year, this mutation, the NYD88 mutation. This is a mutation that Dr. Trion discovered that is present in over 90% of patients with Waldenstrom's. 90%. So that is not a very small thing. Many other diseases would dream of have a mutation that is present in 90% of patients. So Dr. Trion's research has now focused on understanding how this MYD88 signals. How does it work? In that way we can maybe prevent activation. We can, decrease the progression of the disease, and that's exactly what we're working on at the time. So, in general terms, when I find a patient who has these 3 factors, the marrow involved by lymphoplasmacytic lymphoma, the IgM elevation in the blood, plus the mutation of the NYD88 gene, then I can tell the patient, well, the likelihood you have Waldenstrom's is probably around 99.9%. And you will never hear me saying 100. Right, because there are other conditions that can give you similar pictures, and we can sometimes be fooled. But that's, in general terms, this is how we diagnose Waldenstrom's in a formal manner. And as I was mentioning to you, the relation between bone marrow and IgM is true and real for you and for you alone. I'm going to clarify that statement. This is different points of different patients with Waldenstrom's. Each dot is a patient at the time of presentation before any treatment is given. On this y-axis, we have the IgM level that they presented with, and that is matched with the amount of bone marrow disease that they had in the biopsy at the time of presentation. As you can see here, we have people with almost no disease and very little IgM. We have people with very little disease in the marrow and IgM is over 10,000. At the same time, and I'm also only focusing on the extremes just to make the example. We have people with almost 100% disease with almost no IgM production. And we have people with a lot of disease and a lot of IgM production, and everything in between. When we try to trend it with a line that try to explain, it's almost flat. And if you look at this line, it has no statistical significance. And from my perspective, even if it will be statistically significant, I think will not be clinically significant, which is obviously, from the clinical perspective, something that is very important for me, not only based on what the numbers say, what the p-value is, but really what is clinically relevant for the patients. So don't go around comparing your IgMs. That's bottom line what this slide is all about. What 1,000 means for a patient with neuropathy, it could mean that they are in a wheelchair compared to a patient who has an IgM of 4,000 and it's completely asymptomatic, right? So don't go around comparing your IgMs, and this is what it is all about. We get patients in the clinic, and especially the younger patients who are said, well, they told me I have 5 years to live. What am I going to do this? And, I think that is an anachronism that has been just translated, and I don't know why they are not reading the more recent articles. This is just one article, the one that we published from the national database. It's not the only one. We have a lot of data from Europe, the Greeks and the Swedish. They're coming up with their survival analysis. And we have really noticed that in the last decade, with the advent of the new treatments and maybe more educated patients, right? Maybe more educated physicians as well, we are seeing, survival curves that are really looking much better and much better as time goes by, specifically for patients who are in the very young side. I mean, when we compare these curves against the curves of individuals of the same age, sex, and race, right, adjusted, we see that there is a little decline on the life expectancy of patients with Waldenstrom's, but it's not a dramatic decline. It's not like, most patients within 2 or 3 years or 5 years, even 10 years, So we need to be very careful about what we read. And we need to understand that what we say when we see a curve like this, and this is the median, what does that mean? That doesn't mean that everybody has passed at the time of that curve. That means just 50% of patients have passed at that moment. There's still 50% more patients beyond that time. And that's the part that sometimes gets missed. When somebody says the median survival is 10 years, doesn't mean everybody's dead at 10 years. That's not what it means. Just half of the patients have passed at 10 years. The other half still are going and running, right? And that's an important message when we hear these median survival. What exactly does that mean? And obviously, this is when we look at an entire group of people. This is thousands and thousands of patients with Waldenstrom's in one graph. What's going to happen to the individual? That is not predicted by this. That is more predictive. The factors that are more predictive of how you're going to do is how well you're doing, how healthy you are at the time that you begin some treatment, how effective the treatment is when it's given to you, and so many other factors that are not taken into account in graphs like this. These graphs are cold graphs, and I want you to know that. So the individual experience might not match these numbers, and that sounds like a commercial for weight loss. That's exactly what they say, right? Right? This person lost 100 pounds. Yeah, that might not represent what's going to you experience. That's exactly the same. So this is the graphs, and this is what we see in thousands of people. But the individual experience might be completely different. And as you know, one patient's journey is very different than another patient's journey. And you need to have a doctor that understands that, to try to help you in the best way possible, too. Now, most of the patients that come to see me, I would say probably around 50% of patients that come to see me do not need to be treated at the time that we see them. And it's sometimes a hard sell, specifically for younger people. You tell them, oh, you have a blood cancer, but I'm not going to do anything about that. I want to just watch you, right? That is a little unnerving. But if we lay the ground rules that Waldenstrom's is incurable, and patients are going to live for a long time, and if you're going to live, let's say, for the next 15 years or 20 years, is a treatment of a year or 2 years going to change that? It's not going to change that. It's very unlikely that if you have a survival of 20 years, a 1 year or 2 year of treatment is going to change that. It's going to move that to 20 from 20 to 21 or 22. That's very unlikely. It's the same problem that we run in prostate cancer and things of that nature. Very slowly progressing conditions. So if we're not going to cure with our treatments, and we are very rarely extend survival with our treatments, then the goal of treatment is to basically improve your quality of life. And for that, your quality of life needs to be affected by the disease. So how the disease can affect your quality of life? I mean, if 50% of patients are asymptomatic, other patients can have symptoms. And this is the interesting part. This is where my life, is all about. Patients, more commonly than not, are anemic. They have so much disease in the marrow that they are not able to produce a good number of red cells. And that, by far, is the most common reason why we need to treat patients with Waldenstrom's. Having said that, that is not the only way in which Waldenstrom's can cause anemia. It can actually decrease the absorption of iron in your gut. So sometimes patients do not have a lot of disease in the marrow, but they have no iron circulating in their bodies. So we need to do endoscopies, colonoscopies, to make sure that you're not having a colon cancer hidden somewhere there or a polyp that is bleeding. And in most cases, that is not the case. And sometimes there's some iron deficiency. In other patients, we can have cold agglutinins, meaning these antibodies, IgM, react to changes in temperature, and then patients can hemolyze. Hemolysis means destruction of the red cells. So Waldenstrom's can cause anemia using 3 different mechanisms. And the interesting part is when sometimes the anemia is caused by one mechanism, it's not caused by the other mechanism, which is interesting. It seems to be 3 separate diseases because it behaves in 3 different ways. But despite that fact, we have people who present with hyperviscosity, right? They have not a lot of disease in the marrow, but they are hyper producers of IgM, and they will have IgMs of 6,000, 7,000, usually 12,000 in there, right? And these patients are sometimes are anemic, but almost never neuropathic, for example, and almost never have lymph nodes. Some people can have neuropathy, about 20% of patients, and these patients usually are not anemic, and these patients are not hyperviscous. And some patients can present with adenopathy, more like a real lymphoma type person, and these patients can sometimes be not anemic or not have any neuropathy or not have hyperviscosity. So when you look at it, it really looks like they are a number of different diseases, clinically speaking. But because they all have the marrow, and they all have the IgM, and they all have the MYD88, we call them all Waldenstrom's, right? But not everybody is the same. And for that reason, the treatments should not be the same either, right? So the treatment should be very personalized, depending on what exactly is driving your disease and your symptoms. Now, the most important part that I can tell you here is, although anemia is just an example, is the reason to treat 3 out of 4 patients with Waldenstrom's. The fact that you have Waldenstrom's and you have anemia doesn't mean that those are connected. So if somebody presents to my clinic and they told me, I have Waldenstrom's, I'm anemic, therefore they told me that I need to be treated. I was like, wait, let's back up a little bit. Let's make sure that you are not iron deficient. Let's make sure you're not B12 deficient. Let's make sure you're not destroying your red cells for other reasons. Let's make sure. Because if all you need is intravenous iron or injection of vitamin B12, you're better off getting that than being treated for the Waldenstrom's. And the reason I say this is because what we understand about cancer, specifically incurable cancers, is whenever we treat an incurable cancer and we make it better, and we can do that in more than 90% of the times with the treatments that we have available, those cells are going to survive that treatment. They will, because it's incurable. So by definition, those cells are going to survive that treatment. And that means that this disease is going to come back at some point. And when it comes back, it's almost never the same cell. It presents clinically exactly the same, but it will be potentially, and we have that experience with other cancers, a little bit more resistant the next time around. And after the second treatment, it's a little bit more resistant the next time around. And it's always like that. So from my perspective, if you are going to have a 20, 25-year survival span, then let's treat you the fewer times possible, only when it's absolutely necessary, just to prevent that. Because we know it's going to happen. We know it's going to happen, and we need to just, be very mindful of that. So going in, being proactive, trying to be as aggressive as we can, of as intensive of treatments as we can, might not pay off in the long run. Might not pay off. And that can change, right? That can change. I'm a human being. I've been wrong before. I can be wrong again. So that might change. But that's our how we look at this. That's our philosophy on how we look at this. So treat when the patients are in need of treatment, and then we'll talk about what the criteria are, mindful of the heterogeneity, and mindful that we need to prove that any symptom is actually related to the disease, rather than assume that a symptom or a finding is related to the disease. So then that's where sometimes seeing a specialist can help. And I think the reason for that is if you are one of the physicians, and nothing against the physicians, but if you are one of the physicians who have maybe 2 Waldenstroms in their lifetimes, everything has to be black and white, right? Either you need to be treated, you don't need to be treated, and that's it. It's just black and white. For us, when we see about 1,000 people every year, it's not so much black and white anymore. It's very grayscale all over the place. So we have to really have so many factors into account, clinically speaking, physical findings and blood work and mutation testing. So for us, we agonize really over these type of things, and you will see the meetings that we have, the clinical meetings every Wednesday. We are like talking about these numbers and this, so what would be the best treatment for this person and why this and why not the other one, and then we'll just go and then try to look. Everything is grayscales everywhere, shades of gray, more than 50 all over the place, so that's why we need to be paying attention. So and that only comes just with the experience and the expertise of seeing thousands of patients when you get to develop that personalization features. So these are the most common guidelines that are used to define which patients might benefit from treatments. And again, these are guidelines. These are not God's spell. Well, this is Dr. Kyle's spell. So nobody can challenge that. But this is to guide physicians with less experience, right? And the reason we choose this is because most patients tend to be symptomatic, at this point, and that's the reason we need to treat. But if you want to go one by one, we can challenge any of these guidelines at any time. So the fact that you have a hemoglobin of 9.9 doesn't mean that you need to be treated. Let's assume there's no other reason for the anemia, it is the Waldenstroms, but you feel fantastic at 9.9. Then why am I going to give you a chemotherapy or a medication that's going to alter your quality of life just because the number is 9.9? On the other hand, I can have a patient with 10.5. and they feel horrible. Then do I need to wait and make these guys suffer or this person suffer until they reach a 10 or a 10 or a number below 10 just to begin treatments, right? So we need to personalize. Platelets below 100 is probably the weakest criteria that we have. Because really, bleeding problems, platelets below 30, maybe 20,000, right? If we want to really be strict and say, well, this is the time in which this is dangerous. People can have major surgery with platelets of 50, for example. So you could theoretically say, well, it doesn't have to be 100, could be 75, could be 50. So just to give you an idea that we put this just for a safety net, to guide other doctors. But when you go with somebody who has experience, then this might, it's a little bit different. Symptomatic hyperviscosity, that's another problem. Symptomatic hyperviscosity means that you already have, let's say, blurred vision, nosebleeds, headaches. There's already some damage in your organs at that moment. Do I have to wait for you to be symptomatic from your hyperviscosity? Is that in your best interest that you lose sight in your one eye before I say, oh, it looks like you need some plasmapheresis? Maybe we can develop some. So hyperviscosity for me is the strongest criteria to treat. From any of those is the strongest one because that's clearly life-threatening or organ-threatening. So those patients need to be treated acutely, rapidly. If we could treat these guys 24 hours before that happens, it would be great. So we have developed some markers that can tell us who can become hyperviscous. And in that, we had a paper that just came out in which we separated our patients based on IgM at presentation, below 1,000, 1 to 2 to 3, 4, like that, in groups of 1,000. And we really realized that after 6,000, when patients are completely asymptomatic, this is asymptomatic people, then how long is it going to take for them to become symptomatic because of hyperviscosity? When you cross over 6,000, it takes about 3 months, median, that's the trick. 50% of people at 3 months, 50% beyond 3 months, but the median is around 3 months to become symptomatic. So in my clinic, based on that data that obviously comes from our clinic, it's about 800 people that we evaluated. If you are completely asymptomatic, there's no other reason to treat, and the IgM is around 6,000 or over 6,000, then for me is, well, do I really need to wait until you have a stroke to treat you? Maybe we should better treat you before that happens. That might never happen. I'm not saying that it will happen. I never said that. But the risk is high. Risk is higher, and from my perspective, it's up to some degree unacceptable. But if you can present this data to other doctors, they might not agree, right? So this is my perspective. This is my own particular perspective based on the study that we published. So just to give you an idea that, even though we have different criteria, some criteria are weaker and stronger and more acute, and some of them you can play around a little bit. Neuropathy is another issue. We always wait until the neuropathy is moderate or severe to actually treat, because we see that some patients with very mild neuropathy can have that mild neuropathy for decades and never might become a problem, right? But if you can predict whose neuropathy is going to progress, do you really want to wait until the neuropathy might be irreversible? So that's a lot of issues in neuropathy. And basically, for me, the patients with neuropathy are very interesting, and they are difficult to take care of, because it's so subjective. All these are measured stuff. We can measure it. But neuropathy, we cannot. We cannot measure it. It's just the patient's report. I feel like this, I feel like that. There's no measurement that we can do. These EMG or these nerve conduction studies, the electricity and the needles, those are very operator dependent. It doesn't really give me an actual value that I can say, oh yeah, now you're worse, and this is clearly, is very inexact to some degree. Extramedullary disease, a little is that, most of patients would have some degree of lymphadenopathy or enlargement in the liver or spleen, but that will not become symptomatic sometimes for years, right? Typically, we wait until the spleen is actually giving you some symptoms, either fullness or you're losing weight because you cannot eat, or pain sometimes. The lymphadenopathy, if it's around 5 or 6 centimeters, then when we say, well, we need to treat maybe at that moment. But those are things that will come back, and then we'll respond to treatment, and they will resolve. Might not be the same with neuropathy. Might not be the same if you have a bleed in your eyes. That might not recover. So from those perspectives, we need to be a little bit more careful. We have very rarely kidney involvement, maybe around 3% of patients. Pleural effusions, probably around 1% of people, which is accumulation of fluid in your lungs. And very rarely, central nervous system, kind of a meningitis secondary to Waldenstrom's, again, 1% of patients. These are rare stuff. But when you see about 1,000 people per year, then you get to see these things, It's interesting because the people that come from I bring a lot of physicians from outside of the United States to see our practice. I try to be a connection for European and Hispanic physicians. And they were like, I didn't know Waldenstrom was so common. I was like, no, it is not common. We just see them here, which is a different story. So they have, because we see them so often, and they feel that, it's so common. It's like, it's not so common. So, and then obviously cryoglobulins and cold agglutinins, and they have their own manifestations. So this is just to give an idea of what we use to actually say that somebody might benefit from treatment or not. Let's talk about the different options in regards to treatment. This is what is established already. And we're not going to go into any specific, preference, because I don't have a preference. I basically look at the patient and I treat them based on what I think might be the best for that specific case. So one of these is cyclophosphamide. It's a relatively old chemotherapy. In most of studies, at least in the ones that I'm mentioning here, it was combined with dexamethasone and rituximab. And this is important because it's widely available. It's in the United States, in Europe, Asia, Latin America. Is up to some degree very easy to get. And this is really a good regimen. It's a good regimen. We have an overall response rate over 80%. That means that 8 out of 10 patients will have an IgM decrease in at least 25%. So that's very good. That's sometimes enough to make a patient asymptomatic again, right? There's some complete responses that we can see. About 7 to 10% of patients can have a complete response just on cyclophosphamide. And the median survival is until progression. This is not dying. This is until the disease progresses. It's about 3 years. And it's very, up to some degree, manageable. Actually, this is one of the probably more manageable chemotherapies. You can have some nausea, some vomiting, and your blood counts might drop, but you don't lose your hair typically. There's no risk of secondary cancers typically, with this type of chemotherapy. So yeah, this is a treatment that we tend to use sometimes in patients who have neuropathy, for example, and want to give them something a bit more than just rituximab, right? So there are some patients who will do very well with CDR. And there's a number of studies from the United States, and more recently a retrospective study from the Mayo Clinic showing really very similar findings. So this is a regimen that we use in our clinic as well. The other regimen that we tend to use a little bit more frequently is bortezomib-based regimens. And in this specific study, we combined bortezomib with dexamethasone and rituximab. It looks like that combination with rituximab and antibody and steroids has a very powerful effect by killing Waldenstrom cells. So there are at least two studies. Our study, in which we gave it intravenously twice a week, a lot of neuropathy. And the most recent study by Dr. Dimopoulos in Greece, actually is a European study, in which they gave it weekly intravenously, less neuropathy. And again, the response rates are very similar, 80 to 90%, maybe a little bit more complete responses than cyclophosphamide, maybe a little more. It works very quickly. The patients start responding within the first couple of cycles. The good thing about this is there's no risk of secondary malignancy since there's no chemotherapy involved, because bortezomib is a proteasome inhibitor, it's not chemo. Rituximab is an antibody, that's not chemo either. So based on that, it's a relatively safe regimen. The problem is neuropathy. So the way we have actually managed that is actually we have decreased the twice weekly to once a week infusions, like what Dimopoulos does. And more recently, we have moved from intravenous to subcutaneous injections, like they do in myeloma. And we don't have a lot of experience with that. I'm actually writing a paper at the time comparing CDR versus BDR versus BendaR in our clinic. We had about 40 patients with CDR, about 80 patients with BDR, and about 60 patients with bendamustine. Comparative studies, because there are no comparative studies out there. So we are actually running that study. And what we saw is that patients treated with BDR and BendaR tend to have faster responses than CDR. And the duration and the progression tends to be a little bit better as well. But they have other toxicities too. So everything has to be, balanced out appropriately. And obviously, because you're getting the bortezomib therapy, patients need to be on shingles prophylaxis throughout the treatment. That you don't have to be on shingles prophylaxis for CDR, for example. And then the need of steroids, right? But it works. And in our database, we tend to use this more often for younger people that we don't want to expose them to chemotherapy, for example. Safe exposure to chemotherapy for later. Patients with hyperviscosity, in which we need a fast response. We tend to use these regimens for those patients. I will not use this in patients with neuropathy, for example, right? Because it causes neuropathy. So, that is not a good. We have done it in the past in patients whom there was no other options, and it works. But then you have a compound neuropathy, which later gets better, right? So it works as well. But then you make the neuropathy worse at the beginning. So we always have to be mindful of that. The other regimen that is one of the ones that we use very often too is this bendamustine and rituximab regimen. Bendamustine is a chemotherapeutic agent developed in the 40s, 50s in Germany. And it came out in the market about 10 years ago already. And this is the only study in which there's a comparative study between BendaR and R-CHOP, which is kind of a heavy gun chemotherapy that we tend to use for more aggressive lymphomas. But the sample size is very tiny. It's about 20 patients per size. There's another study in which they are focusing just on Waldenstrom's, and it's about 180 patients, but that study has not come up yet. And the beauty of that second study from the Germans is that they are actually going to be comparing maintenance rituximab versus no maintenance rituximab. We'll talk about that in a second. So, but based on this, bendamustine and rituximab tends to be better than R-CHOP. Well, that's a good thing. The overall response rate is over 80% with a very solid complete response rate as well. And the progression-free survival seems to be longer, about 5 years instead of the 3 years of CDR. BDR had about 5 years progression-free survival as well, so very similar in that specific sense. And again, the problem is cytopenias and infusion reactions that you can have, but that's a very, just kind of tiny risk of secondary cancers or secondary leukemia specifically with bendamustine. It's very tiny. In our database, it's 1 in 200. It's 1 in 200. So it's very small. But if you are that one, you're not going to like it, right? But again, extremely well tolerated. Patients do not lose their hair. There's no nausea. It's probably one of the best tolerated agents, works fast, produces deep responses, prolonged responses. So by all means, almost a perfect regimen with exception of this kind of risk. So sometimes in patients who are, in their 70s, in their 80s, then this is the regimen that we tend to use in those patients, and in that specific sense, because it's much better tolerated than bortezomib in older patients, for example, than in younger patients. And we don't want to expose younger patients to chemotherapy. So there's a lot of, again, back and forth. Not that we have not treated younger people with this regimen. We have, right? I mean, nothing that I'm saying is absolute, But it's just to give you an idea of what the preferences are, just based on our experience. But back to real life. This is data from the SEER Medicare database. So every patient here is over 65. Each bar is a year, starting at 1994 all the way to 2013, so 20 years of data. And these are the different agents that are being used to treat patients with Waldenstrom's based on the Medicare database. I want to make it very simple for you. This black area is rituximab single agent. So rituximab single agent remains the most common regimen used to treat patients with Waldenstrom's in the community. And there's no question about that. We published this paper last year, I think, Dr. Olszewski, investigator from Brown that likes to do this population analysis, and we work with him. So yeah, rituximab single agent, despite what we have seen, continues being the most important, the most commonly used regimen. And we like rituximab. It's not that we don't like it. We like it a lot. But when it's used alone, it's sometimes a little problematic because the response rate is 30 to 40%. So it's a lower response rate. But if you are one of these patients, if you are the 2 out of the 5 who will respond, then you're golden because you'll respond really good to it. But the question is, how can we predict who will be in that 40% group and who will not be in that 40% group? That's the difficult part of the whole thing. The time to respond, to initial response, it takes about 3 to 4 months to have the first initial response, and it takes about 2 years to have the deepest response. So that's probably the longest time to response that we have seen. So if you have somebody who you want to respond and you want it to respond quickly, rituximab is probably not the best option for those patients. So in our database, we tend to use single-agent rituximab for patients who we believe that they will not tolerate chemotherapy. They already have neuropathy, or the only reason to be treated is neuropathy, and they have low burden of disease. So we do have a group of people with cold agglutinins or with cryoglobulins alone, things like that. Those are patients that we tend to use single-agent rituximab. It's not that we don't use it, but when we have our typical 60-year-old patient with an IgM of 5,000, we want a quick response because they're symptomatic. This is typically not what we're going to be using in those patients. And again, rituximab can give you infusion reactions. A flare actually can make the IgM even higher at the beginning, which is not progression of disease. It's just the way the cells die. They just release the IgM they had inside of them before they actually die. And that can happen in 40% of patients. And that flare can be a 25% increase, which is not bad, to 300% increase. So we have people who have gone from 4,000 to 10,000 IgM after an infusion of rituximab. And if you are not aware of that, and if you don't know that, then patients can become symptomatic. So we have patients that came to see us with bleeds in their eyes because of rituximab. Well, in part because of rituximab, in part because people don't know about this. So you have to know about this, right? So you can be your own advocates. And about 10% of patients do develop what we call rituximab intolerance, which means that per se, our Waldenstrom patients tend to be more sensitive to rituximab than the regular, and it's not an unusual scenario in which you say, everybody's done with the Rituxan, and I'm the only one who's there still in the infusion room, going very slow with my infusion, and that's a very common place to be, So our nurses know that, and we're trying to educate physicians that the infusions to Rituxan are much more common in Waldenstrom's. This 7% rate in CLL, which is another type of leukemia that is treated with rituximab, is 0.5%. And follicular lymphoma, which is much more common, is about 0.2%. So I'm talking about 15 to 20 times more common to have infusion reactions in patients with Waldenstrom's to rituximab. Now, what predicts that? Nobody knows. Certainly I don't. I can ask Steve, but I don't think he has the answer either. So there are other antibodies that we have been using, other CD20 antibodies. So ofatumumab is more humanized. Rituximab has at least 20% mouse protein in it. Ofatumumab is 100% human, but still is not you human, it's some other human. So you can still develop problems to it, but in some scenarios we have used it and it has worked. So there are ways around these potential problems. We can plasmapheresis patients before they go into rituximab infusions, right? We can consider other antibodies. But again, a lot of refining in terms of understanding what can happen to a patient. And this is the big question now. Maintenance therapy. So Steve Trion did a retrospective study that got published 2011. He took, first comers and all the patients who had maintenance compared to patients who did not have maintenance. But that analysis, at that moment I think was important because I think it served a very special purpose. But I think at this time, in the light of the prospective study that might come up, we did a second analysis in which we actually adjusted for the chemotherapy the patients received. We adjusted for their age, their sex, their race, their IgM level, the IPSS-WM score. We adjusted for pretty much everything else that you could imagine. And despite all those adjustments, we still have a benefit. We still see a benefit of maintenance over no maintenance. And again, not that we're going to give maintenance to everybody. There are people who will not benefit from maintenance. People who did not respond initially will not benefit. People who had a fantastic response, normalized everything, maybe they will have less benefit. And if they're having more and more toxicity as we give them more and more rituximab, might not have the benefit, right? So not everybody gets maintenance, but this is something that we tend to consider a little bit more. And it's interesting because I was talking to Dr. Ansel from Mayo, who are classically anti-maintenance. But when I was talking to him, he told me, well, it's not like we don't give it to everybody. We do give it to some people, right? So we that we are proponents of maintenance, we don't use it on everybody. And the people from Mayo who are not proponents of it, they use it in some people too, right? So again, just to give you an idea, there's no black and white here. And if you might benefit from this, there might be something. So we might have a larger proportion of patients in maintenance. They might have a smaller proportion of patients in maintenance, but that is something that needs to be considered. Now, with the prospective study that is ongoing, the German study that might come out, I hope shortly. So in this way, we can just start using it or just stop using it, right? And we'll have some prospective data to support that. Then obviously we will not have a clear answer. But this is a much more adjusted regimen. I'm writing the paper on this at this time, and we'll be submitting it very shortly. So this has been the treatment approach for Waldenstrom's for years. This is the older brother saying, someday all this will be yours, to the younger brother. And this is exactly what myeloma and lymphoma has been telling Waldenstrom's, right? So all this will be yours at some point. All these agents that we use, pass them on, hand-downs, right? But, that's where this is coming into, some changes we're starting seeing in this treatment. So I think the big discovery is the MYD88 mutation. So this is a whole genome, it's just beautiful. So it's a whole genome, and then you can see this line that is not supposed to be there, supposedly, right? According to Dr. Hunter, he's the one who looks at this and says, I think this is easy, it's clear to see. And I'm like, I have no idea what you're talking about. In any case, when you actually divide this and they look at patients these are samples who do not have any mutation, these samples who have the mutation, we can see a very nice red curve there. That's the normal picture. And here, in the patients with the mutation, we have the red curve, but has another blue curve that was not supposed to be. So the blue curve is the mutation, and the other red curve is the normal. So those patients are mutated in that specific spot. Now, the MYD88 mutation is interesting. 90% of patients with Waldenstrom's. In this study, only 10% of people with MGUS had it. MGUS is a benign condition that sometimes can progress into Waldenstrom's. But more recently, up to 50% of patients with MGUS can have the MYD88 mutation. So that means that MYD88 mutation is necessary for the disease to transform, but something else is needed as well, because people with benign conditions have this mutation. So something else must happen for the disease to actually become malignant and become Waldenstrom's. So that's one thing that we learn from that. The second thing that we learn as well is that this mutation is a point mutation, and it's always in the same spot. It's not random. So it's like we all have a sentence written in our genes, and one letter, that same letter, is always misspelled in that same sentence. So it's very easy to detect up to some degree. The second, and this is a validation of the MYD88 mutations. This is the initial study, and then, other studies from France and Italy and Spain, other places in the United States and Japan and even in India. We have validation of this MYD88. So doesn't matter who you are, doesn't matter what your zip code is or what your continent is, 90% chances you will have the MYD88 mutation in your bloodstream, in your malignant cells. So Dr. Hunter came out with this second mutation, CXCR4, Now, CXCR4 is a bit more complicated because, remember we're talking about the sentence, right? So we have a very long sentence, but up to 40 different letters can be misspelled. And some people have one, some people have the other one, some people more than one at any given time. So to develop a test that could be easily applicable to find up to 40 different mutations in one gene is not very easy to do. So there are not a lot of laboratories that are formally doing this CXCR4 mutation testing. We do it, personally. I think Foundation is actually running these mutations too. And I think Neogenomics was trying to start doing it as well. So there's a number of places. Now, this is trying to be validated too. So there's a study from France and a study from Italy that are actually showing that there's CXCR4 mutation that is real and is real stuff. And we have now gone beyond CXCR4 mutations. We have TP53 mutations, CAR11 mutations, BTK mutations that sometimes can affect how ibrutinib works. So there's a number of different other information genomically that could potentially have clinical implications. And the ones that I care about, as you already guessed, are the ones that have clinical implications. It's nice to see that everybody has a deletion 6q, but that doesn't have any clinical implication from my perspective, not for diagnosis, prognosis, or treatment. But these ones might, and then we'll talk about that in a second. So specifically the MYD88 and CXCR4 combinations. So any patient that comes to our clinic now gets genotyped for CXCR4 and MYD88. So obviously you can be either a wild type, which means your MYD88 is normal, like everybody else, or you can be a mutant. And based on the CXCR4, you can be a wild type, meaning there's no mutations in there, or you could be a mutant. So thinking about this, you can have potentially 4 groups, right? Double mutants, double wild types, CXCR4 only, and MYD88 only. 4 groups, genomically speaking. Now, when we have actually genotyped now about 600 people, that's pretty solid. 600 people we have genotyped. The large proportion of patients, about 2/3 of people, are MYD88 only mutated. About 1/3 of our patients are double mutant. About 10% are double wild type, and no patients have fallen into this category yet, in which they have the CXCR4 mutation but without the MYD88 mutation. We have not seen anybody there yet. And I say yet because you don't know. So this is the distribution of our 600 patients in terms of how the mutations work. And when we actually looked at how they do in terms of survival, if you have the MYD88 mutation, regardless if you have CXCR4 or not have CXCR4 mutations, your survival is the usual one, long, as we have been talking about. But these people who have double wild type, meaning they have no MYD88 mutations and no CXCR4 mutations, that doesn't mean they don't have mutations. They don't have those mutations. They might have other mutations. And their survival is actually much lower. Again, all this is medians, right? But you can see how it looks different. So now that we submitted a paper on this, and we're trying to understand what these wild-type patients are, and the interesting part is actually a group of those patients are actually IgM myelomas, which is extremely rare, but they can present as Waldenstrom's, and they can be labeled as Waldenstrom's, and they end up being a different disease. They could be IgM-secreting marginal zone lymphomas. That is a different lymphoma than Waldenstrom's. But some of them do really look like Waldenstrom's. So we are actually genotyping these patients, try to understand if they're different, how we can differentiate even further. We believe that sometimes clinically speaking we can do these things, but sometimes it's not as easy, So just for you to know that. So MYD88 wild type is better to be seen in a center of specialization, get all this testing to try to understand exactly what's going on in there. So MYD88 basically, and we'll see this a little bit later, signals through BTK. BTK is the proton tyrosine kinase, and ibrutinib is a BTK blocker. So it really made sense to actually try to block the disease by blocking one of the main steps of activation driven by the BTK mutation. So ibrutinib was tried in this study. About 63 patients were included in this study, as you can see here. The age was anywhere between 40s to 80s, so it's a very nice wide, applicability here. 3-to-1 men to women, which is a little bit more men than women than we would like it to. But anyway, that's what it is. Everybody was previously treated, a lot of anemia, very high IgMs, bone marrow involvement up to 70%, lymphadenopathy, and splenomegaly. So a very decent group of patients with Waldenstrom's. And each curve here is the IgM. Each curve is one patient. And the time is, before treatment, cycle 1, 2, 3, 4, 5 in this setting, all the way to 2 years of therapy. And we can see that within the first 2 cycles, the large majority of people had decrease in their IgMs really quickly. You don't have to be a statistician to see that there's clinical benefit here. And the same with hemoglobin. This is each patient is one line. This is the cycles. This is the level of hemoglobin. So they start here, and you see the trend very nicely all the way up. So statistically speaking, the hemoglobin improves, the IgM improves really quickly in these patients. And when we look at the genomics, at the combinations, at the 3 groups that we've been looking, right, at the MYD88 only double mutants and wild types, right, we can see here, I hope it's not too small, but if you are MYD88 only, the overall response rate is 100%, 100% response rate. This is at least 25% of decrease on your IgM. A major response is defined by at least 50% on decrease on your IgM. So that's a deeper response. 92% patients will get there. So this is a very good group to be in if you want to be treated with ibrutinib. Then we have the double mutants. The double mutants have still an over 80% overall response rate, which is very decent, but the major response rate decreases a little bit to about 60%. Now you say, well, this doesn't look so great compared to these numbers, and I agree, it doesn't. But when you look at the data on BDR, BENDA-R, and CDR that I showed you, these are the numbers for those combinations, right? And so even if you would be in this category, right, ibrutinib might not be a bad option. I'm not saying that it's the best option in that group, but it's not a bad option in that group too, And if you have wild-type disease, meaning no MYD88 or CXCR4 mutation, you have about 3 out of 5 patients responded, but none of them were major responses. And typically these patients within a year, they already were progressing. So in our clinic, patients come and they're getting typed for MYD88. If they're wild-type, we don't offer ibrutinib to those patients because we think, it's $120,000 per year for something that is not going to work for not even a year, Again, so that's our own, algorithm in how we look at these things. So the overall survival up to 3 years, pretty much flat, only a couple of deaths. And the progression, obviously a bit more. The people who progress here are obviously the wild typers, right? And some of the some of the CXCR4s already have progressed too, right? Now, as there are 40 mutations of CXCR4 that we were talking about, it's very heterogeneous. So right now what we have been able to basically do is clump them in 2 types of mutations, a mutation that is called missense and a mutation that is called nonsense. I don't come up with this stuff. I just repeat what I'm taught. So missense means that you have the sentence, they remove one of these mutations, right? One of these letters from the sentence, and then the whole sentence gets just shifted, right? It's called frame shift as well. So you still have a sentence. It might not make any sense, right? It's missense, but there's something in there. The other mutation is you have the sentence, and then one of the letters is misspelled, but once it's misspelled, the rest of the sentence just falls off. It just disappears. So that's called nonsense. So we think that the nonsense mutations tend to be a little bit more difficult for ibrutinib than the frame shift mutations, for example, right? So, but this is things that we are learning. All this is just learning stuff. We are in the process of learning this, which is an interesting thing. Good. So based on this, the FDA approves Waldenstrom's. Has been already 2 years and a half. Wow, time flies. It's amazing. So there was a confirmatory study, because we always need a confirmatory study. This is a study from Europe. We actually participated in this study as well. It's called the INNOVATE study. And they did one arm that was only for ibrutinib. The INNOVATE study is interesting because it's comparing ibrutinib plus rituximab, because we add rituximab to everything, versus rituximab alone. Those results are not ready yet. But this is the result from the ibrutinib alone. There was one arm just for ibrutinib alone in patients who were not candidates for rituximab. So these are the numbers, 30 patients,
And the response rates, very similar, a major response of 70%, overall response of 90%, and depending on the mutations, a little better response in patients with MYD88 only, a little less response in patients with MYD88 and CXCR4. The problem with this study is they didn't genotype everybody, number one. So there might be some bias in there. Number two, I don't know exactly what the sensitivity of the MYD88 was, right? Because it all depends how good your laboratory is. It's not the same if I can detect 1 in 100 cells versus 1 in 1,000 cells versus 1 in 10,000 cells. And that could sometimes be a problem when we try to run these tests. You know? But it's good to see that in this confirmatory study, the results were very similar. And we can see here how the IgM from 4,000 to 2,000, 50% within the first 3 months. The responses are rapid on ibrutinib as well. It's not without side effects. It will not be balanced if I will not tell you about the bad things about ibrutinib. So I have divided the side effects between early and long-term. Early because they appear very early on in the first 2-3 months of treatment. Anemia, decrease in the white cells, decrease in the platelets, rash, nausea, diarrhea, all these things patients can experience. Now, in the large majority of patients who experience these symptoms, not everybody does, but if the people who experience these symptoms, the large majority, they resolve, usually by month number 6. But if by month number 6, these symptoms have not resolved, they are not going to resolve. And that's an issue. That's an issue. We have people have diarrhea, they have diarrhea for 2 months, and then it goes away. Perfect. Well, not so perfect, but good that it's not there. But we have people who have diarrhea, still diarrhea at 6 months, that means the diarrhea is not going to get better. Right? So those are things that we need to have in mind too. And again, because we just completed this study, 200 people we have on ibrutinib now in our clinic. About 50 had stopped, 50. So that's about 25%, right? From that, half of the patients stopped because they progressed, half. The other half, that's about 1/8, stopped because of toxicity. So that's 12.5%. So it's not a lot, but if you are one of those 10, then you're not happy, right? So that's that. So that's what I want to say about these early, side effects. And then the long-term side effects, this basically affects everybody. Everybody has at the same risk of bleeding, and that's why we need to stop the drug before and after any procedure to minimize the risk of bleeding. And then, the holdups are shorter for less invasive procedure and more prolonged for more invasive procedures. So what we use for a tooth extraction, which is usually 3 days, versus a knee replacement that is going to be probably 7 days, versus brain surgery is going to be like 2 weeks, right? So just to give you an idea, depending on how invasive the procedure is, then we hold it for longer. Atrial fibrillation is a 10% risk, and it's worse in patients who have heart problems and much less in patients who have no heart problems. People without heart attacks or heart failure or other arrhythmias almost never have this issue, but in people with those problems, they are more likely to have it. Hypertension, and this is something that was reported in CLL patients. We have not seen it in Waldenstrom's yet, this inflammation of the lungs. We have not seen it, but we need to put it here just because, for completeness, right? So, but joint pains, joints. And we have some people that we have to decrease the dose because of joint pains alone. But again, if they resolve within 3-4 months, that's it. They're not going to come back. But if they remain, then that's not going to get better. And we need to be careful too, because when we say, well, we're going to give you chemotherapy for 6 months, and you say, well, I will take these side effects because I know they're going to stop at 6 months. But if we're going to tell you, take this pill every day for the next 5 years of your life, and you have a little bit of diarrhea every day for 5 years, then that's a different story, right? So the grading of the toxicity has to be very, very different in terms of modification of doses and how do we manage it in medications that are given chronically on a daily basis. The way I put this is, well, you have a debt to pay. Either you pay it in big lumps every month for 6 months or tiny lumps every day for 5 years, And again, you just, whatever works best for you. So this is how we understand now the biology of the disease. Before it was just MYD88, BTK, and NF-κB, that's it, like 3 things. Now this is getting more complicated, and this is actually, this is a little outdated, to be honest with you. I'm sure Steve has a new one that is even much more complicated than this. But this is MYD88 and how it really forms what we call a mitosome. A mitosome is essentially a group of molecules that all come together for the signaling purposes. One of the important parts of the myddosome is this BTK, and that's why we block that. But there's a number of other, IRAK1 and 4, NEMO, TAG, TRAF. I mean, there's so many different, pathways that we could potentially block at some point. And now with CXCR4, it's an independent, related, but independent signaling pathway. At some point, it matches and it basically becomes, part of the same pathway. But the initiation of it is very independent of BTK and the MYD88 per se. But they all end up providing, survival benefit to these malignant cells. So as this provides more knowledge and it provides more steps, it provides more targets. To really, can we develop a medication that blocks MYD88 from binding to itself? Can we develop a medication that blocks TAG from binding to TRAF? Can we medication that blocks IRAK activation? So all of these are actually steps that we could potentially target at some point in the future. And that's the beauty of understanding the biology. And again, some of these molecules will be home runs, and some of them might not be, right? But that's what trial and error is all about. And that's why clinical trial participation is key, because if we don't participate in clinical trials, then we cannot advance the science, and we will never know what will be the next best thing and what will not be the next best thing. So based on that, novel pathways, novel targets, novel agents, we have new proteasome inhibitors, very much like bortezomib. Now we have oral ones, ixazomib and oprozomib. These medications, anti-CD30 antibodies, are already approved now for myeloma. And we're going to have a study that's going to be opening shortly on daratumumab. I think Dr. Paloma will talk about that tomorrow. For patients with CXCR4 mutations, we have an anti-CXCR4 antibody. This just activated today. If patients with CXCR4 antibodies who needs to be treated and have not received ibrutinib, we can give ibrutinib in combination with the antibody as part of the clinical trial. If you don't have the CXCR4 antibody, then you are not a candidate for these studies. I think it's the first study ever to basically include or exclude patients based on their genomic profiling in Waldenstrom's. It's the first time. And I think this is the way we're going to be moving into, to be honest. We have other now BTK inhibitors, acalabrutinib, BGB3111, which is the major randomized study comparing BGV versus ibrutinib, head-to-head. The Chinese company already said that if it's as good as ibrutinib, they will commercialize it for half the price. So let's see if that's true. We have this new SNS062 that supposedly it doesn't matter if you have the BTK mutation in there that makes ibrutinib and acalabrutinib useless. This medication would still work even if you have that mutation. So there are second, third, fourth generation BTK inhibitors in the plane, which is good. We just completed our study on venetoclax, which is a BCL2 antagonist. I cannot give you much more information about that because it's still, confidential, but it's looking really, really solid. And then Dr. Trion is working on developing IRAK1 and 4 inhibitors and MYD88 assembly inhibitors, so many options in terms of what can be done in the future. So what I want you to take home is patients with Waldenstrom's are living longer. They are not dying of Waldenstrom's, they're living with Waldenstrom's, and I think that's an important message to have in mind. We have multiple options that are standard, bendamustine, bortezomib, rituximab, ibrutinib, right? There are a few of the treatment options. There are other ones, but I focus on these ones because those are the ones that are, in my mind, provide the best benefit versus toxicity ratio. And that's why we tend to use those medications very early on. There are multiple trials now going on. It's just if you get to the point that you need to be treated, consider a clinical trial. And these are the trials that we're going to be opening in the near future. Actually, this just got open. Bless you. This just got open, and maybe this antibody CD38 against CD38 will be opening very shortly as well. So multiple options. In the future, I think we'll have many other options. And these are the things that we are talking about now. These are not the things that will be available very, very near in the future as well. So with that, I really want to thank you for your attention.